Now I invite Dr. Shaji Hussain. I think he doesn't need an introduction. Everybody has known his skills from yesterday's videos. He is an excellent surgeon, high volume surgeon, and he tackles with all the complicated cataracts that comes to our hospital. So over to you, Dr. Shaji.
Hello. Thank you, Divya, for those kind words. So, as you all know, my topic is customized intraocular lens implantation. How many of you have implanted multifocal lenses and EDOF lenses experienced? Okay, what is your main worry? Because these are the category of patients who chorify you a lot, because they come back, they say that the outcomes were not as they expected it to be. Though the vision is 6/6, we never know what happened. So let's just delve into it. What would have happened? So definitely phaco is the gold standard. We cannot survive without knowing phaco. And now the idea is not just about phaco. It is about a patient satisfaction. The patient's expectations are way too high. They are looking at something more than 6/6. So it's not longer, it was maybe during the early times they were just implanting 18 diopter lenses. So that system of one size fits all doesn't stand at all. We are in the variation of customizing IOLs based on patient needs. So we are trying to tailor. There is like maybe some patients are fit for EDOF lenses, some are multifocal lenses, some are contraindicated for this. So we should have an idea of when to advise what. So we are in the personalized vision era. There are a lot of things happening and we are catering to the patient needs. So to start with, what are these customizable lenses? Start with, we know the first was the aspheric lenses. They were wow factor, the outcome, it was taking care of the spherical aberrations induced, and we had great results. And there has been comparative release assessments about aspheric and spherical. Then came along the multifocal lenses. So it was tackling most of the reading problems. But again, we had factors like night driving were an issue. So there were patients who needed quite a good, at least a computer assist reading or the intermediate vision they needed, but we didn't have an answer there. And they need a quality life improvement. So the challenges and considerations with multifocals were with regard to its visual disturbances, contrast sensitivity, and ideal patient selection. We did have headaches following multifocals. Then came in the EDOF lenses. Now is the EDOF era. So we know the VVT is an EDOF lens from Alcon. iHands, so far I was thinking it is an EDOF, but now it is not. They are coming up with Pure C. So we did expect it to be it was now told to be a mid-range EDOF, actually not an ideal EDOF. Now they are coming out with Pure C. But it was a good lens, to be frank. iHands did quite a good satisfactory patients out. But still there are issues that some patients are facing. So the outcomes of EDOF lenses, now we are all discussing about it. And we are looking up for as customizable lenses in the monofocal aspheric lenses, multifocal and extended depth of focus lenses. And all the above, implantation of toric lenses. We should know how to implant according to the refractive errors or the corneal astigmatism. So we should, before taking up these patients for any surgery, we should know the pre-existing conditions of these patients, like dry eye has to be assessed. Definitely an OCT macula is definitely important to rule out a macular degeneration, though it is not clinically evident. The lifestyle, we should be knowing whether the patient reads a lot or does he drive a lot. These are the two main things. And does he use computers? So the first case scenario here would be a 45-year-old IT professional with significant corneal astigmatism, and he is having cataract. So definitely we have to implant here a toric IOL, and we have EDOF toric lenses also available now. The next case scenario would be of a 60-year-old golfer and photographer. He definitely needs distance, as well as he would be happy if we could give him an intermediate vision. So here EDOF lenses are the answer. Next would be a 55-year-old homemaker enjoying crafting and cooking and reads a lot probably and doesn't drive. So here definitely you can advise a multifocal lens. 35-year-old fashion designer with high myopia, cornea, and here LASIK cannot be done because of thin corneas, and this is something out of the phaco. Here I would be implanting an ICL for him. There are a lot of customizable now scleral fixated lenses. All these are kind of customized lenses but beyond the scope of this presentation. So while planning these patients, optical biometry, of course, corneal topography, aberrometry, OCT macula, these should be there in your armamentarium. And higher order aberrations is something you have to address, and the angle kappa has to be assessed. So this would probably be the only important slide I want you to take home. That is the total higher order aberrations we should be looking at. The mark would be 0.5. Anything between 0.3 to 0.5 is to be dealt with in a middle range satisfied patients. Less than 0.3 is the ideal patients for customized IOL implantations with regard to higher order aberration. Anything more than 0.5 are an absolute no for higher order aberration. Also with spherical aberrations it is 0.1. This is the safest value. Up to 2 would be fine. Comma and trefoil 0.2 is the safest. And anything more than that would be in the mid category, and 0.3 of comma would be a bad result. And never forget the mesopic pupil size. Here glare is something, because these patients who have a pupil size more than 6 would give you a headache throughout, and that's from personal experience. And large kappa angle has to be assessed. All this can be assessed with modern topographers. Now there are certain intra-op consideration that you should be taking up, but that is with regard to the sizing of the capsules and the rotational stability of toric lenses. So what all should I be considering in a surgery while I am going on with a patient who needs a surgery? Or with regard to, I'll be a little careful with regard to the incision, with regard to the rhexis, with regard to the cortex wash-up, with regard to the visco wash-out. I will ensure all that, and about little about the Purkinje images. So what's to be taken care of in incision? Try to be an accurate incision without any irregularities. Ensure that you have a perfect entry, especially with regard to the corneal incision. Next, in rhexis, an ideal size of 5.5 with what I usually prefer to have. And if let's say you have an irregular or a larger rhexis size, would land up in the decentration of these lenses. For these lenses, centration is absolutely important. Cortex wash-up, try to be very careful, do a good polish and ensure everything in the cortex has been thoroughly washed out. Visco, as I said, should be completely washed out, and in these cases we can take up the step where Anup mentioned that a hydro assisted implantation of the lenses can be preferred. While placing the IOLs, and after a good thorough polish, we can do an hydro assisted implantation of the lenses and ensure the Purkinje images are, that is at the cornea and the lens, are absolutely aligned. And all the more post-operatively, ensure you are giving a good education to these patients, because they cannot ensure a good vision right about, they may have a little problem. So visual adaptation is something you have to counsel these patients after your surgeries. Finally, thank you.
Thank you, Shaji. That was an excellent preparation and excellent presentation. As usual, your videos are